3. So thank you, and everyone, welcome to this month's MGH Brigham and Women's Hospital Division for Global Health Equity Global Health Grand Rounds. We're very, very excited to have you all join us today, and very excited to have Dr. Andrew Mujugira as our speaker today. Once again, these Grand Rounds take place on the first Tuesday of every month, and so we hope that you're able to join us as we move forward this year. It's my pleasure this morning to introduce Dr. Mujugira, who is a clinical epidemiologist and a senior research scientist at Makerere University and the head of the Infectious Disease Institute in Uganda, as well as an affiliate assistant professor at the Department of Global Health at the University of Washington, which is where he is this morning. He woke up bright and early to join us, so thank you, Dr. Mujugira. He has years of experience with HIV pre-exposure prophylaxis, efficacy trials, PrEP trials, demonstration projects, and implementation science and safety studies. His current research is funded by the NIH, as well as industry, and focuses on developing methods to build self-efficacy and empowerment, increase antiretroviral adherence, reduce sexual risk behaviors among key populations in Uganda, including trans individuals, through the use of evidence-based self-controlled HIV prevention tools, such as self-testing, STI self-sampling, and ARV treatment, oral injectable PrEP. I've heard many wonderful things about Dr. Mujugira, and it's such a pleasure to have him here this morning. And so I will turn it over to him. And after his presentation, we will invite a session of question and answer that you can enter into the chat. So I'll pass it over to you, Dr. Mujugira. Thank you so much for joining us.
Thank you, Dr. Stone, and thank you all for the opportunity to share the work we're doing in Uganda. I look forward to learning from you as we, in the course of this discussion. And this is my conflicts slide. So the outline of this talk is I'm going to briefly talk about why we work with sexual and gender minorities in Uganda. And then I'll briefly describe HIV epidemiology among trans people in sub-Saharan Africa. I'll spend the majority of the talk talking about the work we're doing with trans people in Uganda, and then talk about the ethical reasons why we work with this population. So in the middle of COVID and the Omicron variant and the Delta variant, it's sometimes easy to forget that the HIV epidemic remains unfinished business. It's fueled by gender inequalities, gender-based violence, criminalization, and marginalization of vulnerable people. And it's important to remember this during this time. The latest NIH strategic plan, I was pleased to note, focuses on improving minority health and reducing health disparities. Here in the United States, among underserved groups that you're familiar with, Black, Latinx, and Indigenous people. But in Uganda, that would also include trans people. And it's good to see the NIH focusing on groups that have been underserved or under-researched in the global health agenda. So I'll move on to talk about briefly the epidemiology of HIV among trans people in a setting. So the latest global health update reminds us that key populations and the sexual partners account for about 2/3 of new HIV infections among adults. And of note is that trans people account for 2% of global HIV incidence, but only account for about 0.4% of the population. And so it's figures like this that motivate the work that we do in an under-researched population, particularly on the African continent. The Global Health Update reminds us about these key populations at high risk of HIV infection. They include people who inject drugs, transgender women, cisgender female sex workers, and gay men and other MSM, all of whom have at least a 25 times greater risk of HIV infection than the general population, but at least in the African setting, are relatively under-researched. At least people who inject drugs, trans women, and also gay men and other MSM. There's been lots of work with female, cisgender female sex workers, but perhaps not as much as there should be with the other key populations. I came across this graphic in a 2016 Lancet paper by Sari Reisner, which looked at the distribution of studies on transgender health at the time the paper was published. And I recall looking at the map that I was struck that Africa, the continent with the highest HIV burden, had almost no studies of trans people, or at least trans women who we know are very high risk of HIV. There was one study in South Africa, highlighted in yellow, that was a sister study of a study also done in Peru. And at the time, I remember thinking, why is there no research, at least at the time that was published, about trans people? In my home country of Uganda in 2017, these are UN FPA data looking at HIV prevalence among key populations in Uganda. At the time, we had some data on prevalence in MSM, but then again, no data on transgender people, which struck me again. On my continent, is very little data. In my home country, no data. And this just motivated the work that we do to try and start some research studies among this population. So by way of background, as we've just said, HIV prevalence among trans women globally is much, much higher than that in the general population. There are fewer data among trans men, and so in the United States, it's at least 10-fold higher prevalence than the general population. Incidence data for trans men are scarce, and even among trans women, we're starting to see studies coming out of sub-Saharan Africa. In one study in Kenya recently published in The Lancet, HIV incidence among trans women in Kenya was about 21% per year, which is much, much higher than that in the general population, which is less than 1% per year. Recent data presented at CROI 2020 highlight HIV prevalence among sex workers in Zimbabwe. And among trans men and trans women, you can see about 38% prevalence, which is higher than that among cisgender women sex workers and cisgender men. These are among the first data from the continent, highlighting prevalence among trans sex workers in sub-Saharan Africa. I look forward to reading the paper when it's published. I haven't yet seen it in print, but this highlights the high burden of HIV in this population. The reasons for this are, I would say, well described. I think we are well aware of the challenges with delay in seeking care because of anticipated stigma, the risk due to sex work, which is partially driven by high unemployment because of structural discrimination. And I'll talk a little more about that later in the talk. At least for trans men, we're finding that they do have sex with cisgender men because of sex work, because of high unemployment. We don't know about biological vulnerability through receptive intercourse. The data are not yet clear on whether hormones or bottom surgery new tissues increase HIV risk. All to say that there's multifactorial reasons why we have an increased HIV burden in trans people. We do know that stigma negatively impacts health. This work shows that internalized homophobia and experiences of discrimination and rejection associated with risk behaviors, as well as stigma enacted and anticipated, which will result in the delays in seeking care among trans men in the United States. These data are, some of them are more than a decade old, but remain true in this population. Some of the qualitative work from Uganda underscores how economic vulnerability drives sex work. Quote, "I have a relationship, yes, but it will not bring me food on my table. So I get a side dish, meaning a sexual partner, to give me what I want. I will go, do what I do, and it's just 5-minute stuff. Then it is finished. I get my 150,000 shillings, about $42, or 300,000 shillings, about $84, depending on how we bargained. Then I will go buy my stuff, meaning my groceries and other needs." End quote. This is a trans woman, age 29, which shows how the priority here is survival, and the sex work is described as 5-minute stuff, which underscores how economic vulnerability drives people into sex work. In our setting, condomless sex is lucrative, as described by this trans woman. Quote, "If someone is giving you 500,000 shillings, about $140, and he tells you, I want it live, meaning sex without a condom, and I don't want your HIV self-testing, meaning in this study, we gave trans women a self-test kit to test their sexual partners. You either take it or leave it, but because we love the money, you will not leave it, end quote. Showing how sometimes people have to choose between earning an income and exposing themselves to risk of HIV. In this setting, sex with a condom is about $14. And so somebody offering 10 times the amount for condomless sex is a really difficult choice for a vulnerable population. I'll now just briefly discuss the oral PrEP studies we're doing among trans people in Uganda. I'm going to present briefly 5 studies that we have done or are currently doing. The Empower study on the top left of your screen was funded through a K grant from the Forget International Center and seeded 4 additional studies, 2 in trans women, that is the peer study and the Tandika PrEP study, and 2 in trans men, Twekuume and Haste. So Twekuume is a local vernacular word meaning let's protect ourselves. And Tandika is also a local vernacular word meaning start. So essentially, these studies are translated, let's start PrEP and let's protect ourselves. And these are among the first clinical trials of trans people, PrEP clinical trials, I beg your pardon, on the continent. So briefly, the Empower study was a randomized trial of 110 HIV-negative sex workers who were randomized to the intervention, which was monthly HIV self-testing, versus standard of care, which was facility-based testing every quarter. All were given PrEP, and RT was available for seroconverters. We conducted 40 in-depth interviews, 30 with sex workers and 10 with their intimate partners. By intimate partners, we mean people they are within long-term relationships who may be a boyfriend, a husband, a father of children. And the primary outcome was PrEP adherence. We found that the PrEP adherence in the study was low, insufficient for HIV protection. There was no difference in PrEP adherence by randomization arm. We used objective measures of measuring PrEP adherence. EAM is electronic adherence monitoring, and tenofovir diphosphate levels in dried blood spots. And they clearly show no difference by study arm and no effect overall of HIV self-testing on PrEP adherence. So this was a null result. This randomized trial, we distributed both HIV self-testing and PrEP. There was no intervention effect of HIV self-testing on PrEP adherence. However, we found what we think may be an apparent intervention effect on PrEP adherence. This was a very small subset of 16 trans sex workers. We have to be careful when analyzing subgroup analysis in randomized trials, but it appeared that there was 4-fold higher PrEP adherence among trans people. And we think that this may have been motivated by access to HIV prevention services. This was the first clinical trial in Uganda for trans people, and they may have been motivated by this newfound access to care. This apparent finding, motivated additional studies, PrEP studies among trans women. So we did some qualitative work in this study, and we found that seeking sexual health care at clinics can be awkward and inconvenient for trans people who face stigma and discrimination during clinic visits from both healthcare workers and fellow patients. This is a quote from the qualitative work, quote, "So with the self-testing kit, the struggle of having to make a line while at hospital, being gossiped by other patients, finding the healthcare worker with so many patients to work on is also done away with. I really love the self-testing kit because there's no queue at the laboratory where people will start assuming that you have HIV/AIDS. You will do the testing at home with no disturbances. So tell me, where will stigma come from?" And this highlights how giving people the tools to test themselves and protect themselves from HIV can circumvent healthcare stigma and discrimination. That said, HIV self-testing in this sample of sex workers did not appear to overcome sex work stigma. Trans women reported not having disclosed sex work to their intimate partners, opting for secrecy to avoid the anticipated negative consequences of disclosure. Quote, I have been in a relationship with my boyfriend for 4 years. When he saw the drugs, meaning PrEP, he wondered why I had them. I had to explain to him everything and test him as well to know our status. I had to show him how it, meaning HIV self-testing, works by testing him. He was not interested in the PrEP drugs, but he started thinking that I was taking PrEP because I thought he was cheating on me. Of course, I did not tell him that I do sex work because that is my business. End quote. So I'm going to share the second study that we did among trans men, which was the HIV and STI risk in transgender men, or HASTE study. This was a small cross-sectional study in which we aimed to explore the sexual experiences and risk behaviors of trans men in Uganda and characterize the HIV and STI risk profiles. At the time we wrote the grant, we did not know how many trans men there were in Uganda, and so we used a conservative sample size of 50, whom we enrolled through snowball sampling and did in-depth interviews to explore the sexual experiences. At the time we did it, this was the first study to assess HIV and STI risk among trans men in sub-Saharan Africa. We conducted this cross-sectional study, collecting quantitative data on demographics and sexual health behaviors, and we used validated social behavioral scales to assess stigma, alcohol use, and depression. In our qualitative analysis, we used in-depth interviews, purposefully sampled participants who had self-report of experiences of stigma and discrimination. We asked about those who had engaged in sex work or had experiences of sex work, as well as those who had drug and alcohol use. Interviews were conducted at the study clinic in a private room at the same visit at which quantitative data were collected. They were conducted in English or Luganda, which is a local language, and we used an inductive content analysis approach centering on descriptive category development to analyze the data. At baseline, this was a relatively young cohort with a median age of 25, most of whom had at least a high school level of education. The median monthly income was about $80 per month, and notably none of them reported sex work at baseline. About 62% had at least one sexual partner in the prior 3 months, and of those who had sexual partners, 42% reported new sexual partners. HIV's prevalence in this sample of trans men was lower than that among cisgender women nationally, which is about 6.8%. However, the prevalence of hepatitis B and syphilis were higher than has been reported in the general population. Again, remember, this is a very small sample, so these proportions may not be representative. They're just an exploratory study. So we present 4 content categories representing the results of the qualitative analysis. Each of the categories describes a different way in which stigma was experienced by trans men in Uganda. The first category describes how the experiences of rape, motivated by transphobic attitudes, led to internalized stigma and shame. Transphobic rape was perpetrated to allegedly correct gender identity and teach trans men how to be cisgender women. The shame and internalized stigma associated with rape made it difficult to talk about being sexually assaulted. Quote, I know trans men who have been raped, so that cannot put them off the risk. When they get raped, you know the risk at which they get raped is also high. Those men, cisgender men, who want to prove a point that you are not a man, you should be a woman. Somebody rapes you just to prove the point that you're not a man, you're a woman, I can actually do it, end quote. The psychological trauma of rape was particularly corrosive to trans male identity. Trans men living with HIV reported that it was difficult to adhere to HIV treatment because taking pills reminded the survivor how they acquired HIV. Quote, I got HIV through rape. It is something that I have not gotten over because I have never talked about it. At times, medicine becomes difficult for me because of the thoughts I get about that incident. For someone who has been raped, there is so much in me that has been damaged since I identify myself as a man. While you will say it happens to every woman, but it is more damaging to me, end quote. Sexual assault was dismissed by family members who prioritized adherence to societal norms over individual self-expression and perceived gender nonconformity as a spiritual problem. The lack of empathy from loved ones following sexual assault further traumatized rape survivors. They were also denied access to post-rape care services, which compromised their mental and sexual health and perpetuated stigma. Quote, when I was 13, I was sent to the market in the evening. And when I was coming back, I was raped. I went back home and I told my grandparent, I have been raped and blood is coming out of me. She did not care and only told me, you climb so many trees, you ride bicycles like men. It is good you have been raped. I cannot forget that statement, and it hurt so much that they did not care. I was tortured psychologically. I was in pain, and I even started rotting as I had not gotten treatment. My grandmother had refused to take me to the hospital because I behave in a certain way and that I am possessed by the devil. So in this setting, climbing trees and riding bicycles is not considered appropriate behavior by a girl. And so the grandmother is telling her that you do things like men. And so it's good you have been raped. And that was very damaging psychologically to this trans person. The second content category shows how structural stigma results in economic marginalization and sex work. Economic vulnerability resulting from lack of employment opportunities and limited education attainment led trans men into selling sex for survival, which exposed them to risk of HIV and other STIs. Stigma affected trans men economically through financial pressure to make ends meet, and socially through the clandestine nature of sex work, which was not disclosed to intimate partners. Quote, some of us have multiple partners, and much HIV risks are a result of our socioeconomic setup. We are doing sex work because many of us have not finished school, and so we do not have jobs. And the best thing we can do is survive, which is through sex work. And we're in relationships with people who expect us to take care of them. You find someone doing sex work with a man, and they're not telling their partner, and there are risks involved because they are having sex with a man for money. They're having sex with their partner for intimacy, and they're not mentioning that they're actually having sex for money outside the relationship. End quote. Avoiding HIV infection was not an immediate priority for participants if exchanging sex for money helped to solve pressing financial problems. A hidden population with limited employment opportunities had to find ways to survive economically. Quote, me to sleep with my boss when he's giving me 200,000 shillings, or about $53, and it can help me solve my problem. At the end of the day, what am I losing? I do it. You don't think of HIV and other diseases. You think about them after solving your problem, end quote. The third content category explains the intersection between individual stigma and disclosure of gender identity or HIV status. There was a common belief that trans men are not at risk of HIV infection because of non-penetrative consensual sex with cisgender women. HIV stigma, coupled with the stigma of being transgender, was perceived to hinder uptake of HIV testing services and status disclosure. Quote, that myth that trans men cannot get HIV is common because people believe that the risk of getting HIV is low since vaginal sex is not penetrative. That myth of them not being at risk of getting HIV stops them from testing for HIV, and you do not want to be the only trans man that is HIV positive. It is already too much work to be a trans person. People are afraid of knowing their status. The stigma is still much, end quote. Disclosure of gender identity to family members was fraught with difficulty and risked ostracization. It was occasioned by significant events like arrest and incarceration, which necessitated notifying next of kin. Such disclosure had significant consequences, like being asked to leave the family home after coming out of the closet because of stigma based on gender identity. Quote, when I was arrested at a club party, I told my friend that, you know what, my mom is going to get to know that I'm a gay. She told me that, you just tell your mom point blank that you're a trans man. I told her that I cannot tell her such things. She will instead hang me. She insisted that I should tell her. I got my phone and called her while crying. I told her that the truth is, I fall in love with fellow women, but I ask for your forgiveness. This is what I feel like I want. She was like, you know what? You are not going to stay here. You might spoil my other children. Don't come back here to spoil my children because I gave birth to girl children only. I got my belongings and left. She told me goodbye. Up to now, we don't communicate. End quote. The fourth category shows how interpersonal and structural stigma lead to inadequate health care. Trans men avoided public health facilities for fear of how they would be perceived and treated by healthcare workers, preferring instead to receive healthcare from trans-friendly facilities such as drop-in centers. These service delivery points offer walk-in services and are staffed by members of key populations or friendly healthcare providers, and are safe spaces where trans men felt comfortable, knowing they would not be asked uncomfortable personal questions. Quote, how is the public going to look at me? Yeah, I have just entered the public hospital. People are staring. People are looking. People want to ask questions, so that uncomfortable feeling is what I don't want. The trans community there is still that reluctance of going there, meaning a health facility. I think most of them now prefer when a transgender organization has a drop-in center. They feel a sense of belonging. I know I will be safe there. No one will ask these personal questions, so I will gladly want a DIC, not a health facility. Healthcare stigma made it particularly difficult to seek care in facilities where they worried about being stigmatized, and where it would be difficult to explain that a man had been sexually assaulted. It was difficult for trans men to articulate their vulnerability to healthcare providers. Survivors of sexual violence preferred instead to ask trusted people within the trans community for help with accessing testing and treatment services. Quote, trans men are not going to tell you that they had a sexual encounter with this person, but then it ended up as rape. They usually never want to open up and say those things to any health facilities or providers. So there's going to be that barrier of he has raped me, and how do I go for screening? What has he given to me? Probably he had a few infections. I just come in secrecy. I confide in someone in the trans community that has access to these services. I will not tell them what is wrong. I will just tell them, help me get an HIV testing kit and some post-exposure prophylaxis. End quote. So in summary, we found that trans men experience stigma at individual and interpersonal levels. Interpersonal stigma resulted in rape motivated by transphobic beliefs that negatively impacted health. They had limited employment opportunities because of structural stigma enacted through employment discrimination. And they feared to access healthcare facilities because of anticipated stigma, and also feared to disclose their gender identity and HIV status And so overall, stigma negatively impacted health in multiple intersecting ways. Interpersonal stigma led to internalized stigma and shame resulting from rape. Structural stigma led to economic marginalization and sex work. Individual stigma, the stigma of HIV, being HIV, living with HIV, as well as trans stigma, led to concealment of gender identity and HIV status. And interpersonal and structural stigma led to healthcare avoidance, all of which negatively impacted the health of trans men in Uganda. I'll now briefly describe the other randomized trials and cohort studies that we're doing. The PEER study is a cluster randomized trial, which is following 80 HIV-negative trans women who were randomized to the intervention or standard of care. The intervention is peer-delivered HIV self-testing, STI self-sampling, and PrEP. Supplies are delivered monthly to trans women in the intervention group, and standard of care is quarterly in clinic testing. All receive quarterly HIV and STI testing and PrEP, and we are conducting qualitative interviews, 30 with trans women and 15 with sexual partners. And the primary outcomes are intervention feasibility and acceptability, as well as PrEP adherence. This study finished enrolling in April, and is currently, we are currently following up participants. We are pleased to read some of these quotes from participants. We took a lot of time to train our staff to create a friendly and welcoming environment at the clinic. And so this quote reads as follows: "I was so much welcoming about that idea of STI self-sampling and PrEP services, because we as transgender persons, we don't access those services due to stigma and discrimination from health service providers. So when the study invited us for that, I was appreciative about it," end quote. 25-year-old transgender women. We are also doing urine tenofovir testing with drug level feedback to support adherence counseling. Quote, "When they tested for PrEP, it showed that it is there. So I later believed in it. If I come back and test for PrEP, but when I know that I've not been taking it, I would be knowing that it is going to show that I don't take PrEP. There's a time she tested, meaning the nurse, and told me that you have not been taking your PrEP very well. I openly told her that it is true. I have not been taking my pills very well. That is when I got to know that it works. You understand? Because I was not taking it very well. In a week, I could take my pills once," end quote. 20-year-old trans woman. And so we find that using these urine tenofovir tests and giving participants drug level feedback helps support PrEP adherence. The second study is a Twekuume study, which is currently ongoing. This is among trans men. It's a small study, 75 trans men, and we aim to characterize HIV and STI prevalence, evaluate PrEP uptake and persistence, and explore the sexual health experiences and risk behaviors of trans men in Uganda. All are being given tenofovir-based PrEP, will be followed for 12 months and receive integrated next steps counseling with drug level feedback using the urine tenofovir point of care assay. The primary outcomes are PrEP persistence at 6 and 12 months. We started enrolling in September, and we are currently about 60% enrolled, and we'll follow participants over the next year. This study builds on the HACE study that I presented earlier, which is cross-sectional, and in which we did not offer PrEP. So this will be one of the first PrEP studies of trans men on the continent. The Tandika PrEP study is a randomized trial in which we're evaluating the feasibility and acceptability of same-day initiation of TAF as PrEP among African trans women. The sample size is 200. We'll roll over 80 from the PEER study I described earlier, which is a class randomized study, and enroll 120 new people to the study. We aim to characterize PrEP persistence on TAF. Participants are randomized to the intervention, which is integrated next steps counseling using drug level feedback for adherence counseling versus standard of care. And then we shall also qualitatively explore how these self-care interventions for sexual health influence prevention choices of trans women and their sexual partners. We plan to do 40 in-depth interviews, 30 with trans women, and 6 with sexual partners. This study is funded by Gilead, who are providing TAF, and TAF has not been studied as PrEP very much on the African continent. And this was probably one of the first studies to assess TAF as PrEP among trans women on the continent. Enrollment began last month and will continue through 2022, I'm sorry. So in closing, I'm going to briefly talk about ethical issues and research with vulnerable populations. So vulnerable populations are variously described as people who are physically, educationally, socially, or economically disadvantaged, and includes racial and ethnic minorities, as well as sexual and gender minorities. The Declaration of Helsinki states that groups that are underrepresented in medical research should be provided appropriate access to participation in research. At the beginning of the talk, I showed you a slide from a paper by Sari Reisner, which showed only one study among transgender people in Africa at the time, that was 2016. There have been a couple more studies since then, but it's safe to say that trans people are underrepresented in medical research on the African continent. So I wanted to frame this through the ethical principles of justice, beneficence, and respect for persons, in which an injustice is defined as some occurring when a benefit which a person is entitled is denied. And so I read your quote where a trans woman said they are unable to access services, sexual services, because of stigma and discrimination. And so we believe that doing HIV prevention studies for trans people and giving them access to combination prevention aligns with the ethical principle of justice. We are using a trans-inclusive approach in agreement with the ethical principle of beneficence. We do extensive community engagement. Before we write any grant, we call a community meeting with peers or civil society leaders. We discuss with them what we think, the science, where the science is going, and hear from them what their needs are. And so we engage them right from the beginning. We have trained our providers and continue to train them to provide culturally competent care. We very strongly work with peers, and all our studies have peer support for recruitment, retention, and adherence. We have deliberately included trans people in research design and implementation. We include them as co-investigators on our grants and also on our studies. And we have included a trans woman on our community advisory group. Every quarter, we hold consultative meetings for all our research participants, in which we also call the peers and our research staff. And it has been gratifying to see that nowadays we, the research staff, just sit back and we can see that when people ask questions, their answers come from within the community, from the peers and fellow participants. And so it is gratifying to see that we are empowering people to solve their own problems and advocate for themselves. And hopefully this work that we are doing is amplifying the voices of a marginalized community. So in terms of respect for persons, we believe that culturally competent care is a basic human right and is essential if we are to get optimal clinical outcomes. We do recognize that sexual and gender minorities it may not be easy for them to disclose information, for example, about rape if you're a trans man, because you will be stigmatized. And we also recognize that in our setting, our healthcare providers are genuinely unaware of the diversity of sexual and gender minorities. It has been a journey for me and our staff, and there's a lot we still don't know. And for me, it's still a journey of discovery in which we are the students and the communities are the teachers, and they're teaching us how to partner with them. And so we hope that our work will be able to empower them and to advocate for themselves and to amplify their voices. We're happy to see that the gender sensitivity training for staff seems to be yielding benefits. Quote, "For my first time to be in this place, I was happy. One, let me talk about the services. The way the services are put up to the people, like they're so accessible. They are there in variety, and the care was good. So I felt comfortable with the place." So before we started this work, we trained our staff and we continue to debrief with them and train them it is very important that we provide a friendly and welcoming environment. And we've heard from our participants that the first thing they do when they come is assess the environment. Am I safe? Are the staff welcoming? Are these people friendly? And we continue to improve. We make mistakes and we continue to make mistakes, but it's a journey of discovery and learning. So in conclusion, HIV prevention research among sexual and gender minorities in settings like Uganda, where these relationships are criminalized, requires carefully threading the needle. We have to navigate the narrow window between the law and also provision of HIV care. The government is supportive of providing HIV care to key populations and providing services, but you cannot be seen to be what is called promoting non-binary relationships. And so it's like carefully following the railway. You cannot divert from that narrow path. And I'm happy to say that we seem to be doing this quite well. We haven't had any issues of participants being arrested because of their participation in research or experiencing any social harms. We have provided gender sensitivity training and continue to learn how to provide culturally competent care and create a welcoming environment. And we believe very strongly that engaging the communities in study design and implementation is key to the success of our research studies. They are our partners in this journey. I'd like to thank our communities, our peers, our participants, the research staff, and our community advisory group for enabling this work. Acknowledge funding from Fogarty and the National Institute of Mental Health, as well as Gilead Sciences. I would like to thank Jessica Hebra, who has worked with me on this journey and has been my primary mentor on my K43 award, as well as Jared Baton, Norma Ware, Connie Kellam, and David Seroda for mentoring me through this journey. I thank you for your attention and I look forward to the discussion.
Thank you so much, Dr. Mujugira. Just an incredible talk about your work as a leader in the space of empowerment and giving voice to a population and people that otherwise would not have it. And I think that's been just, I've learned a lot this morning. I invite people to enter questions into the chat. And maybe as we're inviting that, I would love to just kick it off with just a quick question to you. As you focus on your team providing gender sensitive care and had this training, has that been looked upon as a model for other healthcare facilities in Uganda or care? And I know that full well that in the cultural and political environment there, what that may mean, but I'd love to hear from you, your perspective.
Thank you, Dr. Stone. So thankfully, there are other organizations that have been doing this work for a while. There's one called MAPI, which is actually affiliated to the Ministry of Health, and is a group that provided care. There's also work funded by PEPFAR, which is providing sensitivity training for providers at our regional and district hospitals across the country. So in the public sector, yes, there's those efforts to provide sensitivity training, but we're among the first to do it in a research environment. And so I'm glad to say that it is happening in the public sector, but the public sector is they're overcrowded. As you heard the quote, you're in a long queue in an HIV clinic, you're queuing up with other patients. And sometimes the stigma is not really from the healthcare provider as much as it is from your fellow patients, having to explain yourself in a long line. And so when you're in the private sector, you can provide those safe spaces. Participants may feel more comfortable coming to the private sector. Again, we could do more, we could do better. These are just initial efforts to make sure that people are comfortable.
Dr. Farmer, I see you've unmuted. I didn't know if you had a question.
Well, I did, but I just want to start by saying to Andrew's coworkers, there's no doubt in hearing this beautiful presentation and so sensitively related to all of us that you are pursuing cultural competence. But I think there's something much, much better and deeper in your work, Andrew, and that is cultural humility. It seems to me that that's what you're describing. And although cultural competence may be, an illusory goal, cultural humility is something that we can all pursue. And I've been humbled by your presentation. The most heartbreaking part of this was just hearing the number of 21, I think I got it right, 21% incidence among trans women. And also, of course, the slide about how PrEP is working or really not working now. And I just wanted, this is maybe a technical point, but some of this discussion reminds me of some of the literature on family planning. The question of which of two partners may want it, what kind of, when is secrecy involved, et cetera. And for anyone who's worked in a women's health clinic, you've met people who say, I don't want to have children right now. My husband can't know, or my partner can't know.
Yeah.
And one of the most popular kinds of contraception in that setting has been depot injections, Depo-Provera, for example. And obviously there's movement on this front as well with HIV. And I just wonder if that is figured into your work, or what hope you might see for that, or is it going to be more layered way that people would wish to receive? Is there a role for this kind of technical intervention? If there's more time, maybe later on, I have another question.
Thank you, Dr. Farmer. It's an honor to hear from you. I learned a lot from your work in Haiti and Rwanda and elsewhere. I agree with you about being culturally humble. I think for me, it's been so instructive that of learning how much I don't know. We are trained as doctors to be the person in the room that knows more than anybody else. And when you're working with these communities, you realize very quickly that you actually don't know anything. And so you have to be the student and let them teach you and guide you, because they know better about their own lived experience than you do. And that's been, to me, one of the lessons I have learned in this journey, is to listen, and listen. And I actually create my grant ideas sometimes by just sitting in a community meeting and letting people talk. And then you see the gaps, and then you're able to address them. I agree with you entirely that this reminds me a lot about contraception, and oral PrEP is really just like the contraception field. We're going from oral formulations to injectable formulations, and hopefully to implants. And you're correct. We have done oral PrEP studies. We're seeing challenges with persistence, and we're currently now trying to start injectable carbohydrate studies among our population. So hopefully, we are currently working on a submission to NIH to evaluate injectable PrEP and giving people choice of oral injectable PrEP and following them longitudinal and seeing what is it. Do people come back for injections? Are injections a realistic option for this population? Do we need to deliver injections in facilities, healthcare facilities? Do we need to take them out into the community and give them through drop-in centers? There are a lot of unanswered questions, but I definitely agree that we need to follow the same women's health trajectory, because the same challenges for contraception are really the same for PrEP. So thank you for that comment.
So we had a question in the chat that was asking, saying just a groundbreaking, well-conceptualized program and research. And can you tell us something about your plans for next steps?
Thank you. So next steps, as Dr. Farmer kindly pointed out, is really going to the injectables. Given the stigma, the unstable lives that trans people live, I think that injections may be a welcome step. I held a community consultation with trans women and trans men. And as soon as I mentioned injection and randomized trial in the same breath, there was a protest. We don't want to be randomized to oral PrEP. We all want the injection. And so figuring out how to get these products, I know carbohydrate is not yet approved as PrEP. Hopefully that will occur in 2022. And hope we can work with BIV Healthcare to get access to these populations. So the next steps really are to go to injectable route and maybe as well give them injectable ART, because the same challenges for adherence to oral formulations also apply to treatment, and see whether we may be able to do some work on the treatment side. So the next steps is also goes to a status neutral approach. where you're testing people and depending on the status, you're offering ART or PrEP. I think maybe I have been too siloed in my thinking, and I need to be comprehensive, because as Dr. Farmer pointed out, next year in Kenya, they have an incidence of 21% per year. We need to start people on treatment as soon as possible. So instead of referring them to a place where they may not feel comfortable, why not give them injectable treatment as well? The data, we don't know how well it will work, but that's the reason why we do research.
That's great. Thanks so much. We have a participant who raised their hand, so I'm going to try to let Mark Eisenberg ask his question.
So can you hear me?
Yes.
Yep.
So Andrew, very impressive work. This is as much as a comment as a question, but I taught at IDI for 3 weeks about 15 years ago, a course that brought Ugandan doctors to Kampala to learn about HIV care. And I remember that in a 3-week course, the presumption that everyone in Uganda got HIV from heterosexual sex, and there was no acknowledgement on homosexuality or injection drug use.
Right.
We weren't allowed to talk about it in the course. So I'm impressed with this slow progress, but I'm wondering about in terms of it incorporating MSM sex and within the teaching at IDI, how's that going?
That's a good question, Mark, and thank you for visiting IDI and for building capacity. We're very grateful. So yes, we've done, all the space has opened up a lot. There's an acknowledgement that we have to work with key populations. And so I have a colleague who recently did a small study where we used PRC-delivered HIV self-tests to MSM in Uganda. MSM can access care through HIV clinics that are PEPFAR supported, as you know. The research space, though, I feel has kind of stalled. CDC funded what we call the CRANE survey through Makerere School of Public Health. I've done a lot of work with key populations, but I don't know of any PrEP study at the moment in MSM. I was thinking about writing a grant to evaluate event-driven PrEP. So give MSM a choice of injectable PrEP, event-driven PrEP, or just daily oral PrEP. I haven't gotten there yet, but I feel that there's a big gap regarding PrEP and STI research among MSM in Uganda, and we don't have somebody, we need a champion, somebody to drive that agenda forward. And so talking to an MSM clinic I went to visit in Kampala, you feel that MSM are already doing event-driven PrEP by themselves. It's not in the guidelines. They just read things online and implement. And in many ways, I find the community is actually ahead of us. Researchers, they're already testing out things. And I think that has been the truth globally in the HIV epidemic, that communities are sometimes ahead of the science, and the science needs to catch up with them. So yes, the space is opened up, but much work remains.
Thank you.
Mm-hmm. Yeah.
And then, thanks so much, Dr. Eisenberg, for your question. Then another question came in through the chat. Just once again, praising your incredible work and the many challenges transgender people face in seeking healthcare and HIV prevention services. What are your thoughts on addressing community norms and/or developing individual interventions for the stigma they face?
That's a very tough one. Dr. Farmer may know, and others who worked in our space, that the culture, America's culture wars have really taken root in sub-Saharan Africa. And so the stigma is real. Even us, the researchers, I recall going for my first RB meeting, and I presented my protocol and said I was going to work with transgender sex workers. And a colleague told me point blank, he said, "This is a very risky study. And if you get in trouble, I'm not going to be part of it. You'll be on your own. This is an RB meeting." And a colleague was reminding me of that when I presented results from our study and said, "You remember what you were told?" And so even we, the researchers, fear to do this work because it's a hostile environment. You can easily get into trouble or be shut down. And so you have to be very careful how you implement this work. So addressing stigma is going to be a difficult one. That's another big area we need to address. We feel like you can start small, start at family and individual level, and change minds and perceptions. And I feel like we're already doing that. When we started this study, we had staff members who were very uncomfortable working with with sexual and gender minorities. And you can understand if you've grown up your whole life in a binary and you don't know what you don't know, this can be new and challenging. We have made many mistakes. We still need to learn the language. We need to know how to talk to people sensitively, but we're asking the community to teach us how to do this. But it's not easy. It's not uncommon to hear that participants have been arrested or incarcerated while doing sex work. But slowly by slowly, I think we'll make incremental progress. We have to be careful not to rock the boat while paddling the boat across a river that may have hidden challenges. And the rocks, you need to navigate around the rocks. And sometimes you don't know where they are. But hopefully we can paddle the boat without capsizing. I can't give you I can't give you a pathway that makes scientific sense. It's just incremental progress, putting your foot forward, not knowing what tomorrow may bring, but just doing it sensitively and gently within the confines that you've been given as a researcher. I don't know whether that makes sense.
Thank you. Thank you so much. We're almost at the hour. I was going to, Dr. Farmer, I know you mentioned having a second follow-up question. If you wanted to.
I think Jessica has one in there. Did I see that? No.
Yeah, that was the last one.
No, I won't ask another question. I'll just say that, and I said it in the chat, that this work deepens a very, but an often superficial body of work, not yours. I'm talking about the stigma studies that just seem to proliferate as rapidly as the pandemic did. Mm-hmm. And, to see this kind of depth and a profoundly biosocial approach. I mean, urine dipsticks for tenofovir doesn't get, better than that. And I don't know if you've had a chance to read some of the classic works on stigma, and I just mentioned one of them. But, Louise and I, all of us are connected, some of the folks doing good work here, as is Norma Ware, and I'm sure Jessica and many others. You mentioned the work from Peru, and it's all too rare, but some of that deeper work is interesting as well, or older work rather. Anyway, I just thought that was an amazing presentation, deeply humbling.
Thank you.
Thank you so much. Dr. Asimwe also thanks you for expanding the Empower study to meet the needs of the population while answering important questions. Thank you so much, Dr. Mujugira. It has been such a pleasure having you here, and thank you for sharing your work and your voice with us. And we're humbled and so thankful for this opportunity. We invite everyone to come back in 2022 to join us for Global Health Grand Rounds in January, and we will be in touch. Thanks for joining us today.